Let's bring LP little a in. Talk about what that is, and is it something you find valuable to measure?
I think everybody should have LP little a measured at least once in a lifetime. Those are actually the new guidelines. Some people may want it measured more than once for reasons we can talk about, but LP little a, lipoprotein little a, not to be confused with LP or lipoprotein big A, A1, which is actually the lipoprotein that is on your HDL particles. LP little a is a LDL cousin. It is an ApoB molecule, but it has this very sticky, long Velcro tail on the end. And this Velcro tail makes it much more likely to get stuck in the artery wall. And LP little a has a homology, meaning it is structurally similar to plasmin, which is a part of our clot breakdown process in the body. And we believe that patients who have elevated levels of lipoprotein little a may be less able to break down small blood clots in the arteries, which is important. LP little a also has a relationship to the amount of calcium that can deposit, for example, on the aortic valve. So this is the valve that keeps blood moving out of the heart into the rest of the body rather than going back into the left ventricle. And the aortic valve can get very stiff and calcified over time. And if that happens, you might need the valve replaced. But LP little a can track with your risk for developing calcified aortic stenosis. So the issue with LP little a is that it's predominantly genetically determined. So you basically inherit the number of copies of this lipoprotein little a that you're going to get and how long that tail is from mom and dad. It is also a bit of an acute phase reactant, meaning the levels can change with inflammation in the body. But for people who've measured it repeatedly over time, you will notice some difference in your measurements. We'll talk about, remind me to come back to how it's measured because that's actually different depending on the lab. And so the numbers are not always interchangeable, but most people will notice that they cycle up and down by sometimes even 30-40%, but most people typically stay in this very low risk bucket, in the intermediate risk bucket, or in the high risk bucket, even if the absolute value changes a little bit from measurement to measurement. And the most important thing is to understand, are you in a high risk bucket? Because if you are, then we would like to be more aggressive about managing your overall cardiovascular risk and your metabolic risk.
And what would that look like differently for that person?
In 2026, it looks like the lipidology recommendations would be lower ApoB even further. So that means usually medications and nutritional interventions to get your overall ApoB burden down. There are a number of molecules in clinical trials right now that specifically lower LP little a. None of the available drugs on the market are targeted for LP little a yet. That hopefully we are getting clinical trial data to result 2026 should be the first trials published. We know right now that they dramatically lower LP little a. What we don't know yet is whether they reduce the events associated with very high LP little a. So that hopefully will come out 2026, early 2027. If it's helpful, then those molecules will be available to those patients hopefully in the next couple of years. In the meantime, the statins keep LPA stable or sometimes even increase up to 20 to 30%. The PCSK9 inhibitors tend to decrease LP little a by 20 to 30%, but you cannot, and I've tried, get insurance to approve a PCSK9 inhibitor just because somebody has LP little a. They still say that, it's not an approved indication for that. So, unfortunately, we still have to have this same pathway of failing our cheap generic medication options before we move on. Ezetimibe is neutral for LP little a. For women who go through menopause, LP little a can increase. So the couple of outside scenarios where you might check it again would be if you were in an intermediate LP little a bucket in your premenopausal years. If you are postmenopausal, you might double check your LPA again to see if you're now in a high risk bucket. Does it matter if you change into the high risk bucket late in life? Nobody knows. Menopausal hormone therapy can reduce LP little a. It is not a reason by itself to do menopausal hormone therapy, but it's kind of a nice side bonus if you are considering that anyway after menopause. And the last thing I'll say is Lp(a) is measured in two different ways. It is measured in milligrams per deciliter, which is like the, lipid concentration in your Lp(a), and that's a similar metric to the way the rest of your lipid panel is measured. It's also measured in nanomoles per liter, and the threshold for what is normal or abnormal is different depending on how it's measured. So I have a number of people who, text me or call me for a consultation. They're like, the patient's Lp(a) is 100. I'm like, well, that's really different. If it's milligrams per deciliter, that's very high. If it's nanomoles per liter, that's actually just in the intermediate bucket. It's not that high. So it's important to know what test you had or how it was measured, and to make sure that you're taking that into consideration if you're getting a repeat test done or if you're trying to communicate that with a clinician.
Do we know population-wide a general idea how many people are in that high bucket?
Yeah, it's about 20%. 20% of the population. It's a variable based on ethnicity and geography, but the GWAS figure is about 1 in 5.
And if you were in that category, and maybe you are, what would you do differently? Diet, supplements, lifestyle? You've talked about drugs, but on the other end, natural, what would you do differently?
I would do the same thing irrespective of Lp(a). If I had an increased family risk of cardiovascular disease, I would do the same thing as if I didn't have Lp(a) but still had an increased family history risk, which is, make my nutrition as optimal and boring as possible. Exercise like it's a drug, because it absolutely is. And I would prioritize my sleep. If I had any concerns about disordered sleep, especially disordered sleep breathing, like sleep apnea, I would absolutely get that checked. Make sure my blood pressure is well controlled, and think about how to manage the chronic stress in my everyday life. If, our lives are stressful. I'm never going to say that that's not true. And I would be the biggest hypocrite in the world if I said, well, you just, do something different. Like, I have a stressful job. It's true. And I have a meditation practice, and I have my exercise, and I have my colleagues and friends that I talk to when I'm stressed out. Like, there are strategies to help manage the burden of chronic stress in our everyday lives. And it's really important, right? We actually have really good data that chronic stress is as important a cardiovascular risk factor as disordered sleep, as high blood pressure, as our lipids, right? And it's probably the least acknowledged or managed part of cardiovascular risk.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
I, as a vascular surgeon, predominantly see people who've had a problem already from plaque. Why do you have plaque? Is this an inflammation problem? Is this a lipid problem, an insulin problem?